Professor Zakharowski, which topics are you going to address today in your intensive care lecture?
In the past, we have learned in the last several years that the use of algorithm for the most sick people, like people with sepsis, septic shock, the use of algorithm improves outcome of these patients, and to be fairly honest, improves mortality. So you have more people surviving. And I will present new 3 trials who are comparing the old protocol, the protocol from River, early goal-directed therapy, with some sort of new ideas, but also proving whether it's just an algorithm or whether there's really a change of practice. And there are 3 trials now, one from the States, one from Australia and New Zealand, and a third one from the United Kingdom. And all 3 trials have harmonized their protocols before they started the trial. So I think that's a fantastic way later on for us to compare the data. This was a very strict protocol, very sick people, and there were 3 things they have done according to the protocol. The first one was look at the CVP, and if it's too low, you have to give volume. Look at the mean arterial pressure. If it's too low, do something about it. And number 3, early use of transfusion. So these were the 3 main points, which are also nowadays our 3 main criticism. Therefore, the 3 new trials, they checked whether the early goal-directed therapy is superior or actually the same as standard therapy. Or in the American trial, they had also one where they called it the according to institution, so everybody could do whatever they want. And they looked at the outcome of these patients' mortality at 60 days and 90 days, and surprise, surprise, no difference in outcome. But the outcome was far better than like 15 years ago in terms of sepsis and septic shock. So what we can draw, our conclusion is that over the years there was a change in medicine, and people have adopted. We need to have algorithms, we need to have a plan what we're doing, and therefore then it will be good for the patient.
How are your results of the studies you're presenting changing our clinical practice?
I think there won't be any change anymore because we have done a huge amount of work. We have adopted these algorithms. We have bundles, sepsis bundles and everything. It's probably what we have to realize is that we have to reteach people. We have to make sure that these people are really following the protocols, following the standards, and then the good results will continue.
Regarding the trials you were just addressing, what are the main limitations of these trials?
The limitation I can see is that the trial units where the trials have been performed, they were already some sort of bias because they were trained, they know what's going to happen, they needed to know what were the impact of each pathway, and therefore I think everybody felt observed, so they were under observation. So I think overall the performance was higher than usual, and therefore that probably explains why the results are so good. But that's what I'm trying to say. People in the units who are working with very sick patients in intensive care units, they probably need always some sort of feedback. I wouldn't say observation, but I need feedback that they're doing the right thing. And I think it's a positive thing, and that might improve patient outcome as well.
Which trials do you expect over the next 12 months to change our daily clinical practice?
In terms of just in general, I think we still have a lack of knowledge in people are being operated and then going on an intensive care unit. We don't know enough about delirium. We don't know enough how can we avoid it or how we can improve the outcome, because we know now elderly patients have a higher chance to end up with delirium. So there's quite a lot of room for research questions. Then, of course, the old problem, antibiotics or anti-infectious medication. I personally think we're still too late. We don't have much innovation from the pharmaceutical industry. So these are definitely important questions which need to be raised and studied. But also, I think, in my personal opinion, we still need more information on transfusion and blood products. Because what about elderly patients? In Europe, we know in the next 20 years, a lot of our population will be above 75, and we don't know anything about, do they need more blood transfusion? Maybe less, we don't know anything. So these are the questions which need to be addressed, and I hope ESA and many others are seeing it the same way and doing the research on that, on this matter.